My name is Crystal Thurman, and I'm one of the foundation board members. Along with me today, I also have Christina O'Keefe, and we're going to share a little bit about the foundation in just a moment. But before we move any further, I would like to introduce our speaker, Dr. Adam Macek. And we're so grateful he was here today with us. We know, like we said before, it's bedtime for many of our warriors and maybe even for some of us. But we're so thankful he gave up his time, and his wonderful wife, Linsay, is here with us as well on the other side of the screen. Adam and his wife, Linsay, are proud parents to Makenzie, a little 6-year-old warrior. And they live in Naperville, Illinois, a suburb of Chicago. So I know we have someone here from Chicago listening in. They're an active family, and they love playing golf, soccer, and CrossFit. I think Makenzie really likes CrossFit especially. He has a slight obsession with Chicago sports as well, and says that although it's been a few rough years, but as a family, they love trips to the park, traveling, and going for dinner. Dr. Macek has been practicing chiropractic medicine for over 12 years, while also teaching in higher education for the past 11. He specializes in biomechanics of the body, and his practice has a heavy emphasis on stretch therapy. He works with all patients to ensure that their musculoskeletal systems function as best as possible. And he knows there are many questions about our warriors and some of the challenges they face, especially as they continue to grow. He's hoping he can be a great resource for our community. And in this session, he'd like to address some of the common musculoskeletal issues and conditions that those with Wiedemann-Steiner Syndrome may face, and potentially what can be done to support them as they continue to grow and thrive. So some of those conditions he'll speak about today are congenital block vertebra, hypotonia, chiari malformations, and scoliosis. And then I'll also put something in the chat asking you, if you'd be willing to share what your warrior may face. And so we can ask Dr. Macek to talk about those a bit. Before we move any further, I'd like to ask my colleague Christina if she'd like to share a bit about what she does with the board, or if she has any other words she'd like to share.
Thank you, Crystal, and thank you all for joining us. It's evening here for me, Eastern time zone on the United States, and I'm really excited to see where many of you are coming from, particularly those from Australia, because we're going to have a similar session in a couple weeks. Oh, there goes my light. Sorry about that. Real quickly about the WSS Foundation. It was incorporated in 2016 by parents like us, passionate to advocate and find treatments that can better care for our kids. As a mission, we are focused on serving our global community, and we're focused in 3 main buckets. It's community, fostering our community, providing education, which this session is a great example of, and also research. And we really are making great strides in research. It's, as all of us know, it's a rare condition, and we're trying to align ourselves with strategic partners like Global Genes, like Rare X, in order to get an economy of scale of attention and advocacy, and hopefully meaningful treatments down the road. And so your help into those types of initiatives is critical, particularly as we have some really good conversations with these partners. One of the biggest things they ask us is what's the willingness of your community to support your organization and research. So the more that you can participate with us, please do so. And don't hesitate to reach out to myself, Crystal, or others on the board if you have any questions. But I just wanted to plug that a little bit, Crystal, if that was okay. And absolutely. I think we'll turn it back to you or okay. Dr. Macek.
Thank you. And again, thanks for sharing that overview, and thanks for everyone joining. I see we have a few more popping in, and we even have someone visiting from Puerto Rico. So welcome, and thank you all for being here. And I should have mentioned I'm from Jackson, Mississippi, so I'm sure if you didn't hear the accent before and figure out that I was from the South, now you know. So without further ado, I'm going to hand it over to Dr. Macek and let him get started. And if you have any questions throughout the presentation, feel free to put those in the chat. I'll be monitoring that, and I'll either present those to Dr. Macek in the presentation, or we will do a Q&A at the end, and we can post those questions to him. So I'm going to go ahead and mute myself, and Dr. Macek, it's all yours.
Thank you so much, Crystal and Christina. I appreciate the introduction. I'm really happy to be here today. I think this is awesome that we get the opportunity to kind of get together and just discuss some of the things that may be going on, with our kiddos. And part of why I wanted to do this specifically on musculoskeletal systems with my background is being in the Facebook group. I do see a lot of questions every day, and I see sometimes we're looking for answers. We were there when Makenzie was diagnosed, and so I understand how scary it can be, the frustrations you may have. And so I wanted to try to put just some of our minds at ease with some of these diagnoses that we see, and try to give a little bit more information and kind of make it simplistic as well. So that's kind of my goal for this too. I know a lot of us, when we were in Baltimore or even in Houston, and we sit through these genetic lectures, I look around the room and I can see some of these big eyes, and I enjoy that stuff, but I want to keep it simple for everybody too, because that's the best way you guys will understand for those that maybe don't have a medical background in any fashion. So I'll kind of go ahead. I'm going to share my screen. Crystal, if there's any issues, just let me know, and we should be good to go. Okay. All right. And as I just said, I just wanted to kind of touch base on some of the common questions and some of the musculoskeletal issues that we see through Wiedemann-Steiner Syndrome. As you guys can see, Makenzie right here, she just turned 6 in February, so I had to put a little plug in for her. When we're discussing any of these conditions, I think one thing that's really important to remember is that any of these conditions can really occur in any child, not just those with Wiedemann-Steiner Syndrome. What's important to remember is there's always a reason why we may see some of these musculoskeletal conditions, and it's usually due to some genetic change in that individual. So with Wiedemann-Steiner Syndrome, right, we kind of understand the gene and the chromosome. So a lot of these conditions not only are from just that specifically, but other chromosomal abnormalities, for example, Down syndrome or Angelman syndrome. So there's lots of different genetic mutations that we'll see similar symptoms in. Okay. The first one I wanted to start with is hypotonia. Okay, right? I'm sure I can't see anybody, but if I were to ask for a raise of hands, I could imagine that everyone would say that their child has had hypotonia, right? Or a good portion of us. I think we've had some surveys in the past on that we spoke about in Baltimore, and I remember that being one of the most common things that we see in our children. So with hypotonia, I think one of the most important things to know is just really what it is. I do see a lot of people think hypotonia equals weakness, and that's not necessarily true. So what hypotonia is, it's decreased muscle tone. And so when we think of muscle tone, right, we have to understand what that means. And so muscle tone itself is muscle tension when everything's at rest. And if, for example, you were to have your child just sitting there and you were to take their arm, for example, and maybe move it through motions, you would see some resistance, kind of natural resistance in that movement. And that's what muscle tone is, okay? So as I said before, a lot of these conditions are due to genetic changes of why we have hypotonia. And so our body works in a way where we have our central nervous system, which is our brain and our spinal cord. And then off of that, we have peripheral nerves, and those innervate all of our organs and our muscles in our entire body. Okay, so there's a pathway from our brain to our spinal cord to those nerves and to the muscles, where really any kind of component of that chain can be affected and lead to decreased muscle tone. Okay, so it's important to note that hypotonia is not a disease, right? If you're diagnosed with hypotonia, there's a reason behind it. I think of it like fibromyalgia. Maybe some of us in here have been diagnosed with fibromyalgia as well, and that means more muscular pain, but there's an underlying condition causing it. And so that's what we try to get to the bottom of, is when we have hypotonia, what is that reason why. And we know with Wiedemann-Steiner syndrome and the genetic mutations that we see, that is a cause to cause that hypotonia. Now, once again, where along that pathway occurs can be different in every individual. Okay. So when we look at symptoms of hypotonia, we can see here floppiness. So once again, that decreased resistance with passive movement, postural deficiencies, mobility deficiencies. So when our Wiedemann-Steiner kiddos are born, I remember my wife Linsay and I always being so concerned with some of those initial milestones that Makenzie wasn't meeting, not being able to hold herself up or flip over or whatever it was. A lot of that is due to hypotonia. Okay, so you can kind of see here in the picture, there's an infant here and just not having that muscular tone to help support their body in certain positions. Some of the other things that we can see with hypotonia are breathing and speech difficulties, right? Because we have to remember when we speak and when we're breathing, these are all controlled by muscular actions. So it is important to remember that when we have some of these other symptoms that we're seeing, maybe feeding issues. I know Makenzie had that, and that's something we went through, and reflux. Some of that can be due to muscle tone throughout the GI system. Okay. And what's important to know about hypotonia as well is that a lot of this can improve with age. Okay. Children that are young, their brains are developing, their nervous systems are continuing to develop. And so we can improve that kind of neurological connection as these children get older. Okay, and there's ways to do that, and I'll get to that here in just a minute. Okay, and as I said before, hypotonia does not mean weakness. So if we have an individual with low muscle tone, it's something where if we have them activate that muscle, they actually can be pretty strong. So muscle strength can be present, but when it's at rest, that tone is what is deficient. Okay, and as I said before, with all Wiedemann-Steiner syndrome cases, majority of them, I should say, hypotonia is present, as well with a lot of other genetic syndromes. So if you look at not Wiedemann-Steiner, but other genetic diseases that are out there, hypotonia likely is one of the common things that we'll see. What I also wanted to say too is the term hypotonia, hypo, so that prefix kind of tells us what's going on. So the term hypo means decreased or diminished. And so in this case, we have diminished or decreased muscle tone. We do have what's called hypertonia, and that's not as common with Wiedemann-Steiner syndrome. Hypertonia or excessive tone is usually due to injuries within that central nervous system, the brain and the spinal cord. Okay. So when we look at how do we treat hypotonia, therapies, that's really kind of the best way to do it, right? So occupational therapy, physical therapy, speech therapy, even before a diagnosis is there, when you can identify something, and that's kind of the idea behind a lot of musculoskeletal system diseases, is when you see it, you just treat it, right? No matter what the cause is, you're treating what you see. So improving balance and coordination. Okay, stimulating some of that brain tissue, the cerebellum, right? That helps our body kind of really keep muscle tone active and keep balance, trying to stimulate that nervous system to help improve that connection, right? That central nervous system all the way down to the muscle, improving that neurological connection. Improving motor and sensory skills. So just as important as that muscular component is, the sensory information coming in is important as well. And then ultimately, like I said, it's really about kind of getting our nervous system to fire as much as we can and increasing that pathway to allow our body to work the best that it can. Other things that can be done, nutrition, just trying to keep ourselves healthy. So B vitamins are a great way to keep our nervous system healthy. If you do look at maybe supplementing your child with like a daily vitamin, always consult with your doctor to make sure it's the right fit. But B vitamins have shown to really help nervous system function, especially during the developmental stage in our young WSS kiddos. Okay. One of the other common musculoskeletal abnormalities that we do see with Wiedemann-Steiner syndrome is a congenital block vertebrae. Okay, so this is looking at kind of the spine. And so within our spine, we have three main components. We have our cervical spine, which is our neck. We have our thoracic spine, which is our mid back. And then we have our lumbar spine, which is our lower back. I always so I do teach in higher education. So I kind of use these little gimmicks to help me remember things. And so the easiest way to remember the number of vertebrae in each of those levels is meals of the day. Like what time would you eat breakfast, lunch, and dinner? 7, 12, and 5. So 7 a.m., noon, and 5 p.m. There's 7 vertebrae in the cervical neck, 12 in the thoracic, and 5 in the lumbar. So any of these levels, we can see sometimes these vertebrae will actually fuse together. And with Wiedemann-Steiner syndrome, the most common fusion that we do see is C2, C3. So in the neck, that's second and third vertebrae. In this picture, this is actually a 3-4, but we can see this kind of tail here. That's 1. This would be 2, and then 3 would be kind of down here. So 2, 3 is the most common with Wiedemann-Steiner, but it can happen at any level. Okay. Once again, the reason why we see blocked vertebrae is because there's a genetic mutation during the fetal development stage, which is going to not allow the spine to properly form as it should. A lot of times, blocked vertebrae are an incidental finding, meaning we don't even know it's there, and we have an image done or we have an MRI done, and then it's just listed there on the report like, here it is. So in most cases, it's asymptomatic. We don't necessarily have any symptoms that present with a congenital blocked vertebrae. It can cause some pain, and I'll kind of talk about that here in a minute. But it is something that, like I said, we just kind of find on accident most of the times. Okay. And there is a syndrome called Klippel-Feil syndrome, which is when we have multiple levels of fusions or blocked vertebrae. And that really is a more severe and progressive case of just a singular level. So if it is something that can be diagnosed, it is possible that someone with Wiedemann-Steiner syndrome can also have Klippel-Feil syndrome. It's not common or likely, but it is something too that if we do see multiple levels where there's blocked vertebrae, that would be the diagnosis of that syndrome. So as I mentioned before, many cases, there's no symptoms noted. We can see some limited motion, right? So our spine in each of these levels, in each of these vertebrae, they kind of move in certain patterns to allow our body to move the way that it should. So if we do have a fused vertebrae, it can limit the motion in that area. It also can lead to some muscular tightness. So with that, the muscles that surround those levels may be tighter because they're kind of protecting against that limited motion. So we can see, for example, maybe rotation of our neck isn't as what it needs to be, or flexion and extension, maybe bending forward and backwards, can be limited depending on where the level of that fusion may occur. Okay. It is possible, like I said, that pain can occur with these. So in between each of these levels in our spine, we have nerves that come out. And as I talked about before, those nerves branch off of our spinal cord and they go and they innervate all of our muscular tissue and our organs. So if there is impingement of a nerve, maybe at a level of a congenital block, it can maybe cause some radiating pain or lead to some dysfunction in our GI system. Okay. What happens basically is the disc, there's a cartilage disc that sits in between each of those vertebrae. And when it fuses, we kind of get rid of that disc, and now we have one large vertebrae. And so now the biomechanics of our spine have changed. And then the normal load that our body takes, right, the weight of our head and things that we do day to day, that load is now distributed above and below those levels. So we may see some breakdown of the cartilage discs at levels surrounding that congenital block vertebrae. So it all comes down to, like, what do we do when we see this, right? It's important to remember that when you have a congenital block vertebrae, you're not going to do anything different, okay? You may work on some stretching and some mobility training and some muscular strength, but there's nothing surgical that you are going to do in a case where there's one congenital block vertebrae. There's no additional treatment you're going to really have to seek out. It's something that's just there, and you just kind of work around it. And like I said, in most cases, it's not going to cause really many issues. Crystal, trying to kind of hop in real quick. Are we good with everything as far as questions before I kind of move on?
Thank you. Yes, actually, there was one question pertaining to the previous information. Okay. And the question is this block always congenital, or does it sometimes develop over time?
Good question. Yeah, so it can develop over time in a sense of if you have severe arthritic change in your spine, and this is progressed years and years down the road. Usually we see things like this in maybe our 50s and our 60s, but if there's complete degeneration of a disc between vertebrae, it's actually possible that arthritic change can cause those vertebrae to essentially kind of fuse together and really limit motion. So it wouldn't be something where if we have a normal looking spine, for example, in an infant, and then all of a sudden, like at age 10, there's congenital block vertebrae, we wouldn't see that. But like I said, in later years in life with arthritic change, degenerative change, we can see fusions through arthritic changes in the body.
Great, thank you. At this time, I don't see any other questions, but if anyone has questions, again, don't forget to put them in the chat and I'll be happy to share those with Dr. Macek.
Thanks, Crystal. So another kind of musculoskeletal condition that we see a lot of, and not even just in Wiedemann-Steiner, but also just the general population, is scoliosis, okay? And really what scoliosis means is we have a lateral or an abnormal curvature of our spine, along with some of these vertebrae being rotated. So as we can see in the picture here, on the left side, we have a normal spine. So if we were to look at an individual from the back, we'd like to see a nice straight spine. And as we can see with scoliosis, we have curvature, okay? And so curvature can range. It could be very mild. It could be a few degrees. It could be very severe. It could be up to 45 or 50 degrees. It really kind of depends on the progressive changes that we see with that specific individual. Okay, but it can be found in all regions. It's most commonly found, in the thoracic spine, but it does occur in the cervical spine and the neck, and then also the lumbar spine as well in our lower back. Most cases are idiopathic. So when you see the word idiopathic, it just kind of means we don't really know where it's coming from, but there's likely some type of genetic or hormonal change during fetal development or early adult or early childhood years that is causing this to occur. So we know with Wiedemann-Steiner syndrome, being that there's a genetic mutation, that there is the likely increased risk that we may see changes with our skeletal system. Okay. Hypotonia can kind of relate with scoliosis. As we mentioned before, hypotonia is important for keeping our posture what it needs to be. And so if we have decreased muscle tone in our postural muscles, if we do have scoliosis or maybe a really mild form of scoliosis as a young individual, if that muscle tone is not supporting our posture, it is possible that that scoliosis can continue to progress as the children is as a child is growing through those adolescent years and through those growth spurts, which is one of the reasons why it's really important. If you can identify it early, you can kind of help treat it and kind of really minimize the progressiveness that the curvature may eventually reach to. Okay. So with scoliosis, there's not, like I said, a definitive correlation where if you have Wiedemann-Steiner syndrome, you're going to have scoliosis. But once again, there's that genetic component that will always kind of link the two together. So as I said before, some can be very small degrees of curvature. Some can be more severe. And so early diagnosis is really important to help correct that curvature. And many cases are conservatively treated. So if you do have a child, whether they're 2 to 5 to 7 to 9, even up to 15, right? It's important that you continue to work on maintaining and reducing the ability for that curve to get worse. So a lot of times when we look at treating cases, it's through physical therapy, it's through stretching, it's through strengthening. Although some cases that are more severe may constitute bracing, for example. Even in really rare severe cases, there may be surgical intervention in which maybe rods have to be placed along the spine to really help try to keep it in place. So these are rare, they're not common, but it is something too that it is possible that we may see some of these cases, throughout our community. So how do we recognize scoliosis? Okay, I think when we look at our children, it's important to look for any maybe abnormalities that don't seem normal. So if we looking at our child and we see our shoulders are very uneven, that may be an indication that curvature of the spine is occurring and causing one shoulder to elevate. If you have your child or any individual that has scoliosis bend over at the waist and you're standing behind them, you may see that one of their shoulder blades is much higher or their shoulders are elevated because of that change in curvature of our spine. And the hips too, right? So in our lower back, if we have curvature, you may see the right or left hip be more elevated. That may be an indication that scoliosis can be present. So we can't diagnose scoliosis off of, our shoulders being uneven. or our waist or our hips are unlevel, you have to do that through imaging. And simply like a digital x-ray can be done to look at the spine and to diagnose that. MRIs would be more, when we look at imaging itself, MRIs are more for our soft tissue. So looking at, for example, muscles and tendons, cartilage. And so in a case where we look at scoliosis, x-rays tend to be the best way to diagnose that. Okay. So we can have pain with scoliosis. Okay. Back pain isn't really normal for kids. So if a child is complaining of having neck pain or mid back pain or lower back pain, something's obviously going on. And so it is something that we should always have in the back of our minds of maybe there's something structurally that can be occurring causing these issues. Okay. In some cases, especially severe cases where the curve is significant, it is possible that that curve can actually compress lung tissue. It can compress on our heart area as well. The heart kind of sits in a little chamber just left of your sternum. And so if there's curvature that's pushing on that heart, it can affect kind of the way the heart functions and the blood flow through the body. But if your lungs are compressed, breathing can be difficult for some individuals with more progressed cases of scoliosis. So if we are diagnosed with scoliosis, right, as I said before, what do we do? Most cases are conservative treatment. So physical therapy, really working on mobility, right, looking at muscle tone, core strengthening. The more strength that we can have, the more stable our bodies are, and then therefore the less likely that curve can get as bad as it wants to. Specific programs can be noted. So there are places that will look at curvatures and they'll look at the degree and the way that it's moving. And then they'll come up with plans to treat that individual to strengthen certain areas and to really stretch other areas, depending on kind of how the body is affected. So it is important to remember that every individual's scoliosis is going to be different. No one's is going to be the same. So there may be certain muscle groups that need to be worked more so in one individual than another. Okay. Chiropractic adjustments, I have to throw my little bread and butter in. I think movement's a great thing, whether it's muscle tissue, which is my practice. We do a lot of stretch therapy, but then I also adjust everyone as well too. So the adjustments are just getting some movement in the spine. Motion's a good thing. Okay. I know sometimes people aren't familiar with kind of chiropractic and they're not sure, what it is. And there's different ways that you can approach how we can get some movement in the joints. It doesn't have to be crazy aggressive, hearing all these cracks. I know that's like a big thing on TikTok and YouTube now. But it's simply just, certain positions that we can put a child in to get a little bit of movement and help get a release within that joint tissue can be helpful when it comes to treating scoliosis. My daughter, Makenzie, has been, I don't know, she sees some videos of me adjusting people, whether it's through our practice advertisements or something on my phone. And now every day we have this little kind of bench where we get our shoes on and stuff. And she lays down and she grabs her neck and she does this little twist thing and she gets in her positions and she actually loves being adjusted. I will say that with her, and as we know with a lot of Wiedemann-Steiner Syndrome cases, constipation is prevalent. And so I think with adjusting her lower back, which is getting those nerves to stimulate that kind of work her GI system, we have noticed some improvement with that. So that's been really cool. Diet and exercise can be really helpful. We want to maintain good body weight just to help kind of reduce the load. So if we have scoliosis and we have curvature, the load on that spine can be pretty heavy on certain areas, especially the apex of that curve. And so just trying to keep the body moving and keep us healthy, just to do everything we can to put ourselves in a good position. As we said before, bracing, there are different types of braces that can be implemented. So as the child grows, they wear a brace so many hours per day to try to minimize that curve from progressing. And then really the most important thing with scoliosis, especially if we catch it early, is to monitor, right? So, if there's no really changes in curvature as we get older, that's great. Okay, if we can minimize it and go the other direction, even better. But what we don't want to see is that curves continue to increase year by year, and then those growth spurts hit, and now it really takes a toll on the body. So that's why trying to get these things early can be really helpful. Once again, we don't have to rush out and have our child imaged for no reason. But if you do notice things, them complaining of pain, or you're starting to see like their shoulders are very unlevel or hips are unlevel, maybe just an idea to have it checked out. It's pretty easy. It shouldn't take more than, like I said, just a picture to kind of look and see how things are going. Okay. And then I know some of our warriors are on growth hormone. I know that's been a big topic over the years. And so there have been some studies that have looked at growth hormone use with individuals that do have scoliosis, because the idea being, if there is scoliosis and curvature, that growth hormone can actually progress that curve to be worse because we're kind of increasing that hormone so quickly into the body. There's no significant changes really in the angle from what they've studied. So if you do have a child that maybe has scoliosis and you are on the growth hormone, there's really no significant worries that that growth hormone will progress the curvature in the spine. All right, Crystal, hop in again. Any kind of questions?
Yes, actually, there was a question that popped up just after we left the previous discussion, and it is, can you elaborate on GI issues with the cervical spine? So you briefly mentioned that.
So when we look at GI issues, so there's all different. So our gastrointestinal system, it starts in our mouth, right? So when we look at our GI system, it really starts technically starts when you look at the food you're going to eat and you start to salivate and you start to really get those enzymes moving within your mouth. And then as we put food in our swallowing, right, our tongue and those muscles within our throat help move that content downward through our esophagus, and then once again into our stomach, small intestine, large intestine, and then out. So any GI issues, okay, all these organs have nerve innervation, right? So they have to function. They have to be told what to do. They have to be able to work. So if we have any nervous system impingements or any nervous system dysfunctions, whether it's in the central nervous system or a branch of that, which can be anywhere throughout the spine, the GI system can be affected at those levels. So when I look at, for example, like the large intestine, right, kind of down in our abdominal region and our small intestine, our lower back, which kind of sits in that same area, the nerves off of our lower back are what are actually innervating those organs. So if you have like a cervical spine, like a C2, C3 blocked vertebrae, that C2, C3 nerve isn't really doing much for your stomach or your small intestine or your large intestine. It's more focused on some of the muscles that are directly associated kind of in the upper neck area. Okay, so it is something to think about if we do see GI issues, kind of where they are occurring. And then once again, just because we have a stomach or a small intestine dysfunction, it doesn't mean that there's a nervous system issue from the spine. It absolutely can be. But we know, once again, with Wiedemann-Steiner syndrome and genetic mutations that kind of control our entire body, there may be a genetic mutation directly within the small intestine or the large intestine or the stomach that are causing these issues. So I know it's kind of not the perfect answer, but it is important to remember that when we have changes at any point, it can be nervous system, it can be the organs themselves, it can be the muscular system. So it's hard to sometimes identify exactly what is causing those. And that's why like treatments are trial and error, and it's kind of a collective approach. When we do treat these conditions, we're kind of doing a little bit of everything to help these individuals.
Thank you. And two more questions.
Okay.
One is, can an individual with Klippel-Feil syndrome, can they be adjusted at a chiropractor?
Yeah, so I've actually, I had one case about 2 years ago, probably mid-20s, never had imaging done, and I imaged his cervical spine, fused the entire way down. Absolutely would not adjust that because nothing's going to move. Even in blocked vertebrae, you can still do mobilization techniques and adjustments, you know, above those levels and below those levels without any issues. But the reality is you're not going to get a congenital blocked vertebrae to move. But with a severe case like Klippel-Feil syndrome, personally, I would be more against the adjustment component to those areas because they're not going to move because they're fused. I'd be really more focused on the muscular side because those muscles in those areas are probably so tense and locked up that motion is even more limited. So we know we can get some flexibility back in the muscle tissue. That would kind of be my focus versus the joints, which no matter what we do, they're not going to move.
Mm-hmm. Okay, thank you.
Mm-hmm.
And the next question is actually going back to the previous discussion about hypotonia. And
Okay.
it is, can hypotonia affect menstruation?
Absolutely, it can, right? So once again, muscles kind of control our entire body. They control all of our functions that we have. And so with menstruation, right, there are effects through the uterus and uterine contractions during menstruation that have to occur. And so it is possible that the muscular tissue within the uterus, those linings that we have in there, can be affected, which can have some effect on the menstruation itself.
Okay, thank you.
Mhm.
I don't see any other questions at this time. Thank you, Doctor.
Of course. So last, I have two more kind of items to touch on. This is more of a neurological thing that we'll see in some cases with Wiedemann-Steiner, more because of a sometimes skeletal component to it. So there's something called a chiari malformation. And so our brain and spinal cord, our brain sits in our cranial cavity, right? And then our spinal cord comes down into kind of runs right in the middle of all those vertebrae. And we have fluid that surrounds our central nervous system, which is our brain and spinal cord. And it really protects and allows for buoyancy. So when we hit our head, and as unfortunately I know with Makenzie, that happens a lot, and I'm sure with a lot of our kiddos in here, it protects our brain and our spinal cord. So it's like a cushion. And that fluid that's in there sometimes can be compromised because of changes in our spine, and that can lead to issues as well. So we can see that we have our brain stem, which actually connects the brain to the spinal cord itself. And then we have like this almost like little mini brain, which is that cerebellum, which sits in the back of our head. And that's the really kind of important part of our brain that's more for balance and coordination. Okay, these ventricles that you see here, that's really where the fluid moves through. So there's these openings within our brain tissue, these hollow spaces, and these ventricles are what fill with that cerebral spinal fluid to help protect it. And then it kind of goes around the entire brain and then also protects the spinal cord. So when we have a chiari malformation, what that kind of truly means is that some of these contents within this area, so maybe our brainstem, but cerebellum mostly, actually kind of move downward through the foramen magnum, which is an opening at the base of our skull. Okay, so why would something with Wiedemann-Steiner syndrome, like why would this occur, right? Well, we know that a lot of times with Wiedemann-Steiner syndrome individuals, we may have smaller skulls, we may have smaller brains, and that may lead to some abnormalities and just kind of the positioning of how our brain sits within kind of the cranial cavity. Okay, these are things that occur usually during fetal development. So there are genetic components as the fetus is growing that ultimately cause these things to happen. And as I said before, right, Wiedemann-Steiner syndrome cases may have smaller brains or smaller heads in general, which just can lead to a possible increased risk for a malformation to occur. Okay, there has been some studies that have shown Wiedemann-Steiner individuals do have a smaller foramen magnum, or that opening at the base of our skull where that brainstem is coming down and that spinal cord is essentially exiting our body. Okay. Most time with a chiari malformation, there's really not many symptoms. So you don't, with the most common, which is also the mildest cases, you don't necessarily know that this is actually there. A lot of times it's through an MRI that can be done. If you have an MRI of your brain, this would show on that. But most cases, we don't know that it's there. Sorry, go back. When we look at symptoms, like how do we know we would have a chiari malformation? The symptom list is so long, it could literally be anything like sneezing, coughing, pain, tingling. I mean, you name it, that's a symptom. So there's no like direct symptom that's going to lead you to think you have a chiari malformation, especially if it's the more mild case, which is why a lot of them are incidental findings. But there are some more severe cases where the symptoms are more prevalent that would indicate something is not correct. So there's 4 different types, 1 through 4, 1 being the most common. And when we have a type 1, and I'll kind of just mostly focus on this, but that's where our cerebellum or the tonsils of the cerebellum push downward. So as we look through this picture, we can see the tonsils of that cerebellum kind of pushing down through that opening. This would be a type 1 chiari malformation. This would be the most common that we would see. And once again, a lot of times they would be asymptomatic and an incidental finding for that case. Type 2, now we have the cerebellum and then some of the brainstem tissue remember the brainstem connects the brain and the spinal cord. Some of the brainstem actually moving downward through that opening. This is also called an Arnold chiari malformation, and this is more severe. When that brainstem starts to move down through the foramen magnum, now it's a more severe case that needs attention. Type 3, this is a very kind of severe case where we have cerebellum and brain actually moving through an abnormal opening in our skull, which can be a life-threatening complication. And then type 4, the cerebellum is very underdeveloped and kind of really moves through a very rare case as well. So, with our children, if you had like a type 3 or type 4, you would pretty much know from the beginning that something neurologically wasn't right. And these are things that would probably be addressed by doctors immediately. Like I said, most common here, type 1, a lot of these things we don't necessarily see. And what it means when we have these is that we can be at an increased risk for maybe, further injury. I should say further injury can lead to the possibility of more symptoms should it happen. So if our brain and our brainstem and our cerebellum are not properly positioned and something were to happen, we may see more neurological effects if the chiari malformation is present. And so there's actually this, when I was doing some research putting this together, I came across this study. And so I just have the link here. And so I could probably hyperlink it. I didn't do that for this, but it's pretty long. But really what it does is it looks at a lot of Wiedemann-Steiner individuals. I think there's maybe 12, and it looks at the cranial vertebral junction. What that means is it looks at kind of this area right here, and it's looking for abnormalities within these individuals. So with those with Wiedemann-Steiner, I think out of the 12, a lot of them had some sort of like kind of cranial vertebral abnormality. Most of them were not anything severe, but small changes within the skeletal system that, once again, maybe if an injury occurs or other maybe complications down the road, that we may see more neurological changes in the body. Okay. It also showed some of the Wiedemann-Steiner cases in this study having like missing ribs, which I don't think there's a direct correlation. That could just be kind of a coincidence. I think there was one that had an additional rib, or cervical rib, which is uncommon. But once again, we do see those in all types of individuals, not just Wiedemann-Steiner. And likely, once again, mutations at some point through the fetal development causing these changes to occur. So those genetic mutations can be from anything. And then this is just one last slide here, sacral dimple. I know Makenzie has one, and I've seen some questions in the past, what does it mean? What do we do? Simply, it's just a little indentation kind of above the buttocks. It's harmless for the most part. There's no direct cause. Once again, we know there's probably a genetic component to that. If you see something like this, you don't necessarily have to worry about it. There's no treatments that can be done. It's asymptomatic, and you just it's just part of who they are. If you do have a child born and they have a sacral dimple, and now we start to see some other features with that sacral dimple, for example, sometimes there's a tuft of hair that is present, that can be more of an indication of a more severe complication of what we call spina bifida. And spina bifida is where sometimes during fetal development, our kind of neurological formation doesn't fully finish. And so there are cases where spina bifida is asymptomatic and we don't even necessarily know that it's there. But there are cases where it can be more severe. And so developmental stages within the fetal part of that kind of nervous system growth, we can see some of these changes that occur. There's also the tether cord. This is where the spinal cord now kind of attaches to tissues and it doesn't move freely. And that can lead to a lot of nervous system deficits. Once again, like the spina bifida and the tether cord would be more likely increased if we do have a tuft of hair with that sacral dimple. If it's a sacral dimple by itself, pretty much nothing to worry about. It's just kind of who your child is. Okay. All right. So I kind of want to leave some time for some questions. So I hope that was helpful for everybody. I only touched on a few different musculoskeletal conditions. I wish I could go over as many as I could, but we'd be here for weeks and weeks. But I did want to kind of point out some of the common ones that we do see and just hopefully give you a little bit more information on those. Maybe put your mind at ease if your child does have some of these. And like I said, I hope that was helpful for you guys. So if there's any questions, we have about 12 minutes here. I'm more than happy to answer those.
Thank you so much, Dr. Macek. That was extremely informative. And although my child is 13, I definitely learned some things and can actually apply those to him today.